Respected seniors and office bearers of IAP TNSC, good evening to one and all. We'll start today's DIP program on postgraduate clinics with the pediatrics prayer. குழந்தை மருத்துவ நிறைந்துதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும் நோயின் துன்பம் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வுமாக எல்லா குழந்தைகளுக்கும் அவர்களின் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம் கற்றல் ஈகை அன்பு அமைதி ஆகியவற்றின் தூதரலா என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாதவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குங்க. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். நன்றி.
Thank you, Dr. Gopal. Now I welcome our dynamic president, Dr. Ismail sir, to deliver a president's letters.
Yeah, thank you, Dr. Rajendran. My dear friend, Dr. Gopal Subramaniam, and all other IAP TNSC members, respected judges, the chairperson of the day, Dr. Thangavelu sir, and the moderators, Dr. Puvanagi and Dr. Ramesh Kumar, and the students enthusiastically waiting to present from ICH. I welcome you all on behalf of IAP TNSC. And of course, I think you have got a very good chairperson today, the doyen in pediatrics, Dr. Thangavelu sir, who was our teacher. And really, it is fortunate you all going to interact with such a nice person. I just listened to him in the recent IMA, Innovations in Pediatrics. I think the topic has to be, it was very well done by Dr. Thangavelu. I was really astonished the way he had spoken about the knowledge he has. With these few words, I wish you all a happy learning. Thank you.
Thank you, Dr. Ismail sir. It's my pleasant duty to welcome all the faculties today. First of all, I welcome our chairperson, Dr. S. Thangavelu sir. He is editor-in-chief IJPP and director of pediatrics, Dr. Mehta Children's as well as multi-specialty hospital. As Dr. Ismail sir said, he is one of the godfather like that figure in Tamil Nadu IAP. So again, on behalf of IAP TNSC, I welcome Dr. Thangavelu sir. And I welcome today's moderator, Dr. Puvalagi, Professor of Pediatrics, is ICH MMC. And I welcome Dr. R. Ramesh Kumar, Associate Professor of Pediatrics, and he's the first, I think it's the first intensivist, pediatric intensivist graduated from PGH Chandigarh, and he's coming to Tamil Nadu. So currently he's in Jipmar, Pondicherry. And I welcome all the students from ICH, Dr. Sajita Banu and Sasikala Sasiraga from ICH Chennai. And I welcome all the judges today, Dr. LLRC Madam Balashankar, Janani Shankar, and PRC sir, and Srinivasan sir from Pondicherry. I welcome all the office bearers and as well as Trustee Dr. Gopal Subramaniam, Dr. Tirumurugan Joint Secretary, all the EB and OB members. And once again, I welcome one and all. Now it's over to Dr. Thangavelu sir.
Thank you, sir. Good evening, sir. Good evening, all the senior colleagues and students. I'm very happy to be part of this. Rajan introduced that whatever the learning, we learn from every side. We learn from our seniors like Professor Srinivasan sir. We continue to learn from youngsters, 3 years, I think. Sasireka, Sajita, and Sasikala. We keep our mind and ears open to continue to learn from it. That is why we rejuvenate ourselves. That is the secret of our rejuvenation. It's a very common thing is R.K. Narayan, the great writer, used to classify Chennai weather as hot, hotter, and hottest. So he classified Chennai as 3 seasons, hot, hot, hottest. For a pediatrician, there are only 2 seasons, dengue season, non-dengue season. Anything from June to February is the dengue season. Only in 2020, dengue gave way for COVID, so that COVID occupied the scene. Otherwise, from 1996, we are facing a lot of children with dengue and facing the morbidity of these children. So I'm very happy to be part of this teaching program. Particularly, most of the case presentations will be on chronic disease, which we don't see commonly in a day-to-day practice. This being a common topic, we are all waiting eagerly for to listen from all the students as well as from the moderators, Professor Puvalagi and Professor Ramesh Kumar. They already been introduced. Professor Puvalagi is the Professor of Pediatrics, Pediatric Intensive Care Unit of Institute of Child Health. I think probably she is one of the persons, one of the resource persons having a long, more number of papers published in the literature. And that Ramesh Kumar, I think he did a lot of research on ICB monitoring, snake bite and scorpion sting, one of the bright students from PDA Chandigarh. From this, I hand over the mic to Dr. Puvarigi and Ramesh Kumar to introduce the students and to start the presentation. Thank you very much.
Thank you so much for such nice words, sir. So now I would like to place my sincere thanks to IIP-TNSC for having given an opportunity for this nice learning session today. And here we have our PGs, Dr. Shajita, Dr. Sashireka, and Dr. Sashikala. Very sincere, dynamic, hardworking, smart PGs, as you all will know now for the next presentation. They're here to present a child with fever with thrombocytopenia, which is a day-to-day problem for all of us. So without wasting much of a time, I would like to go to the presenter, Dr. Shajita, for a presentation of this child with fever and thrombocytopenia. Take over, Shajita, please.
Just one minute. We are not going to interfere with you, the presenters. We'll allow you to have the full presentation. At the end of the history, then we'll start asking questions. So you continue your presentation till the end of the history and summing up the history.
Dr. Ramesh Kumar, a few words. Dr. Ramesh Kumar.
Dr. Ramesh Kumar.
Unmute panunga.
Yes. So good evening to all, and really I am also eager to learn a lot of things from the students, because every day I am learning from the students only, because they will ask a lot of innocent questions. I hope the students also going to give opportunity to learn me also. At the same time, I will also try to contribute myself whatever knowledge I have. And once again, thank you for the Untitled Chapter IAP for calling me as a moderator, and in presence of Thangavelu sir and Puvalagi madam. So thank you for calling me, and hope we can enjoy this session.
Yeah, PGs, you can proceed. Yeah.
Hello.
Good evening, sir. Good evening, sirs. Good evening, ma'am. Am I audible, ma'am?
Mute panikku through. Yeah.
I hope we are audible, ma'am, sir.
Yeah, please proceed.
Is the screen visible, sir?
Yeah, visible. Yeah.
The screen is visible.
Yeah, you can proceed.
Okay, sir.
Through mute panung through, please mute.
Good evening, sirs and ma'am. We are postgraduates from Institute of Child Health, Chennai. We are here to present a case on fever with thrombocytopenia. I'm Shajita. She's Dr. Sasireka, and she's Dr. Sasikala. Good evening, sir and ma'am. Moving on to the case history. We have a 6-year-old female child with us, who is the firstborn of non-consanguineous marriage brought by her mother, whose reliability was good. They are hailing from Vilivakam. Mother's chief complaint was the child had fever for the past 3 days, vomiting for 1 day. The child is lethargic for 1 day and abdominal pain for 1 day. History of presenting illness. Fever was present for the duration of past 3 days, which was high grade, intermittent in nature, not associated with chills or rigor. The fever subsided with paracetamol, and the child is afebrile for the past 1 day. The child had vomiting for the past 1 day, which was 3 to 4 episodes over the past 1 day. It contained food particles, not blood-stained, it was non-bilious, and it was a non-projectile vomiting. The child had a history of abdominal pain, which was acute in onset, diffuse, not radiating to any other regions, and it was a dull aching type of pain. History of reduced urine output noticed by the mother. The child usually passes 6 to 7 times per day. The child now passes 3 to 4 times a day. No history of pain during maturation or altered urine color. History of reduced food intake for the past 1 day. History of rash, which was diffuse and erythematous in the extremities, with redness of eyes noticed for the past 3 days. No history of loose stools. No history of joint pain or swelling of the joints, no yellowish discoloration of the eyes, no severe muscle pain, or no pallor noticed by the mother, no history of cold extremities, no history of bleeding manifestations like bleeding from the gums, nose, bloodstained vomiting, bleeding PR or reddish urine, no history of facial puffiness, swelling of the limbs or abdominal distension, no history of cough or difficulty in breathing, no history of seizures, headache, or altered sensorium. Treatment history for the above complaints, child was treated in a nearby PHC with oral paracetamol at 10 mg per kg per dose 4 times a day. Past history, no history of previous hospitalization for the child, no known comorbid illness, no history of any drug intake preceding the illness other than paracetamol, no history of prior dengue infection as known to the mother. Antenatal history, she's a first pregnancy, spontaneous conception, registered and immunized at a nearby PHC, had regular antenatal visits, iron and folic acid tablets taken, no history of with rash or constipation during pregnancy, no gestational diabetes mellitus or pregnancy-induced hypertension or hypothyroidism or jaundice during the pregnancy. Child was born by normal vaginal delivery at full term at RSRM lying in hospital with a birth weight of 2.8 kg. The child cried immediately at birth, breastfed within an hour of birth and no NICU admission. Postnatal history, the child was exclusively breastfed up to 6 months of age. Complementary feeds were introduced thereafter. Age-appropriate milestones were attained as per the mother, and child now is schooling in first standard with a good academic performance. Immunization history, the child is immunized up to age as per the national immunization schedule. No optional vaccines were taken. Family history, no similar complaints in any of the family members. No history suggestive of symptomatology of COVID in any of the family members. Nutritional history, the child takes mixed diet. By 24 hours recall method to assess calorie and protein intake, the child has nil deficit in calorie or protein. Socioeconomic history, they are a nuclear family. They are living in a pakka house, 2 rooms, 4 members, no overcrowding. They have a separate sanitary latrine and kitchen. They use corporation water for domestic and drinking purposes. No waterlogging nearby house, and they belong to lower middle class according to modified Kuppusamy scale. There is no history of contact with any COVID positive patients or tuberculosis patients, and the child has no known allergy to any drug or food items. So summarizing this history, we have a 6-year-old female child with us with complaints of fever, high-grade fever with rash, who is afebrile for the past 1 day, and with complaints of abdominal pain, vomiting, lethargy, and reduced urine output for the past 1 day. We would like to offer the probable diagnosis as a viral fever first with warning signs, UTI, malaria, and after ruling out the infections, we would, as a diagnosis of exclusion, Miss C also. Sir?
We will follow this order. You can ask questions first,
Puvalagi, unmute.
followed by Puri, and then I will come as a third one. It's a turn for Dr. Ramesh to ask questions.
Dr. Puvalagi, unmute.
Yeah. Dr. Ramesh sir can start the questions if you.
Yes, ma'am. The presentation is, I noticed all the points was covered and history. I'd like to ask one question on the regarding, if you are, what is you are analyzing your analysis of the history. Suppose if you are sitting in OPD, so what are the possibility you will think about upfront? Number one. And you told that only viral fever. So viral fever means it's broad spectrum. So with the given the season, and you can directly think about the dengue. Viral fever, the dengue should be upfront one. Okay. So okay, my question is, if you are sitting in OPD, if you are sitting in emergency room, okay, what could be your analysis and thought process based on your history?
So the child first presented with high-grade fever spikes initially in the fever itself for the 3 days, and then now child is afebrile for the past 1 day, following which the child has some warning signs like vomiting, lethargy, and abdominal pain, sir. So considering the epidemiology and the season, we would like to consider dengue first. And we will consider to admit the child because the child is a dengue with warning signs.
And second thing you mentioned in your history, there is a redness of the eye. Okay. Yes. And do you want to ask any other additional question with respect to the redness?
Whether the child had any discharge in the eye? whether it was purulent or non-purulent.
Very good. That's very important. Okay, there is a, and how this redness in the eye, in addition to the discharge, is going to help you. What are the thought process will undergo in your mind, backup mind? That means I must look at this redness very carefully in your examination. Okay, your mind, by the time your mind will be say something in the backup. So what are those conditions, or what are your thought process?
So, high-grade fever with the conjunctivitis, non-purulent conjunctivitis means we can think of Kawasaki. In MISI also, we can will get only a non-purulent conjunctivitis, our DD.
Very good. Unless otherwise, if you are not
Scarlet
going
fever
to
will
think,
also have a non-purulent conjunctivitis.
yeah.
Sir.
Unless otherwise you are not going to think, you won't examine in your clinical examination finding. And I will ask separately, but rather than saying conjunctivitis, when you are saying Kawasaki disease is not a conjunctivitis, it's a conjunctival ingestion.
So, ingestion. Okay.
Conjunctivitis is different and conjunctival ingestion is different. Okay, and that's very important in the examination finding. And you mentioned no optional vaccine was taken. What are the optional vaccine you are expecting in this child?
If the child had been prescribed outside with an NSAID or a steroid, then the
No, optional vaccines. You mentioned child was immunized for age, but
Yes, sir.
not taken any optional vaccine. Okay, what are the vaccine you are expecting as a optional the last 5 years? Because the 5 year before is scenario is different. Now the scenario is different. Okay, that's what I'm saying.
typhoid vaccine, sir. Typhoid vaccine, cholera vaccine, meningococcal vaccines, influenza vaccines.
I think the influenza vaccine is not introduced last 5 years in Tamil Nadu. I don't know, because madam might aware about those things. Pneumococcal vaccine. Recently, pneumococcal vaccine is introduced by the, but last 5 years not there. Yeah, it's a common vaccine also is there, no? Pneumococcal vaccine. I don't know rotavirus is when they introduced, because 5 years scenario is different, because you specifically categorically told is optional vaccine. So you would have asked, then how can you verify these things with simple history wise?
Vaccine, sir.
What history you will ask first with respect to the vaccination?
Whether the child was immunized in a private hospital or a government hospital.
Yes, very good. Yeah, if record is there, you can examine the record.
We can
Very
examine.
good. Yes, very good. Do you observe any in the treatment history? Do you observe anything with this prescription wise? Anything is wrong?
No, sir. The child was given appropriate dose of paracetamol 4th hourly, 6th hourly. No NSAIDs was prescribed according to the mother. Only paracetamol was given.
Dose is okay with you?
Paracetamol is 10 mg per kg per dose in dengue.
Is it okay with you?
Yes, sir.
Do you want to give 10 mg per kg or 15 mg per kg?
For oral, we can give 15 mg per kg per dose. Sir. For rectal and IV, we use the 10 mg per kg per dose. But in dengue, we prefer only 10 mg per kg per dose, 6th hourly, 4 times a day. Sir.
Okay, fine. Because some variation is there, but I am happy with your thing.
Okay.
And small correction with respect to the presentation, because
Yes,
when
sir.
you are going to write the case history in your exam, if you assume that this is the exam presentation, try to
Okay,
avoid as much as possible abbreviations.
Okay,
Okay.
sir. Okay, sir.
Okay, madam.
Yeah.
Okay, sir.
Okay, sir.
Shajita, you were telling about the paracetamol dose.
Yes, ma'am.
Why were you very particular on paracetamol dose? Was it routine or you had something in your mind? In a child with suspected dengue, why did you think about the dose of paracetamol? What was in your mind?
Any higher dose of paracetamol will further aggravate the liver injury, which will already occur in a dengue child, and coagulopathy also it will worsen.
Okay, does that mean a regular dose of paracetamol, you are safe that there will not be any injury to the liver? In
Yes,
a child with acute febrile illness, Regular dose of paracetamol, is it safe? Or in an underlying diseased liver, even that can do problems?
If the child is a known case of liver disease, then paracetamol should be used cautiously only.
Okay. So in case this child has received a higher dose of paracetamol in a shorter duration, what would be your line of further evaluation, or what will be your line of thinking if the child has received a higher dose more than 60 mg per kg in 24 hours?
I will also assess whether the child is associated with any other symptoms of liver disease, like whether there is sudden dip in sensorium, whether there is sudden jaundice, something like that, like whether the
Signs
child
of
has
paracetamol toxicity,
whether it's there or not. we have
Think
to-
about paracetamol toxicity also in a child who's presenting with dengue with liver involvement. Okay, right.
Okay.
You said in your past history, no prior history of dengue fever, right?
Yes, ma'am.
What was in your mind?
If if this is a secondary infection and there was a prior primary dengue infection, then the child will go in for a more severe dengue at this presentation, ma'am. Because of the presence of enhancing antibodies due to the prior infections.
Okay, so maybe the child had a subclinical infection, was not aware. Fine.
Yes,
Okay. Is there any condition where the primary infection itself can cause severe dengue?
In a child less than 6 months, if the child management antibodies, passive transfer of maternal antibodies to the infant, when the child develops dengue infection postnatally, then the child will develop chronic severe dengue.
Even with the first infection.
And
Okay. Okay. You said something about chronic illnesses in the past.
Yes, ma'am.
What chronic illnesses you had in your mind with relevant to this case presentation of a likely dengue child? Why is it important?
In any dengue child, whether if they have a past history of, or they are known case of asthma, or they are known case of type 1 diabetes mellitus or hypertension, or they are taking steroids for any cause like nephrotic syndrome or any underlying malignancies, or it is a hemolytic disease like G6PD or thalassemias, these children are more prone for complications, ma'am. So we would like to ask whether they had any comorbid illness.
Okay, so that assists as well in your triaging to decide on whether to send home or
whether the child to admit or not.
Even if these children come with only a probable dengue fever, we have to admit these children.
With no warning signs also, we'll have to admit these children with high risk.
Okay, that makes an important finding to decide on triaging as well. Okay, so this child in 3 days fever, you said fever, dengue season, epidemic, so you thought about dengue. Any other possibility would you think if this child is a non-dengue child? 3 days fever with a rash. Any other possibility would you think close to the diagnosis if it is otherwise not dengue?
Fever with rash can be in other viral illnesses also, like measles and other in chikungunya.
Okay.
And then recent times misc, ma'am. In bacterial infections like scrub typhus, leptospirosis, presence with fever with rash. And then if we go for non-infective causes, rheumatological causes like SLE can have fever with rash. Malignancies, the petechiae and purpura can be interpreted as fever with rash.
Child was treated outside with some drugs.
Drug-induced fever, ma'am.
Okay, okay. Yeah. Sir, I'll move on to Thangavelu sir for his comments and questions.
And Dr. Sasiraga, really very nice. A very nice, crisp presentation. It covered most of the aspects of the case history. And I also managed the Googlies of my examiners also.
Okay.
So I just ask you, you're also very much updated. No, your history included also waterlogging. But only
Yes,
that
sir.
your answer is not correct. No waterlogging.
That is what I everywhere here due to rain, sir.
So that's very nice that you even recently covered recent issues also. I think it's a nice way to cover COVID vaccine history also in the family. So routinely, if you ask a family whether the parents are immunized against COVID, grandparent, that will give you two things. If they're immunized, this child is less likely to catch COVID, number one. Number two, you have an opportunity to talk to them, to counsel them to take the COVID vaccines. So better include the COVID vaccine history in the family history also.
Okay.
Then you told about fever and redness of the eyes, whether it is sticky or non-sticky or discharge or no discharge. What are the conditions will present with the redness of the eyes and fever? We already discussed. In addition, we can also include viral examples like measles and leptospira. They can also present with the fever and redness. And then very important history, you started with viral fevers, simple viral URIs. Usually they do not persist beyond third day. Most of the time they have respiratory symptoms like cold, cough. In general, not absolute, in general, dengue does not have any respiratory symptoms. That is one thing which you make you to think more about dengue. So a child persisting on third or fourth day and presenting with the newer symptoms. This is the only disease, if I remember correct. After the fever subsides, the new symptoms begins. After the fever subsides, child develops newer serious symptoms like abdominal pain or vomiting. Can you think of any other condition where after the fever subsides, child develop vomiting and other symptoms? Sajita, Shrika. You can think about like something like viral hepatitis, where the fever might subside because of the condition of the underlying illness. Child may have vomiting, abdominal pain after the fever subsides also. And the third is drug-induced. Mainly, predominantly, any child developing symptoms, serious symptoms after the resolution of fever is the only one condition is dengue. Other condition you can think of like viral hepatitis. Third is a drug-induced. Some probably they would have given NSAID, which would have caused vomiting. Otherwise, dengue is the only thing. Can you move your slides? And I asked you, what are the DDs you will think? That Ramesh Kumar asked this, when you're in OP, what are the DDs? You can move the slide further if you have included my slide also. So what are the DDs you will think? In a child coming with fever on fourth day. Yeah. Can you move it further? I don't know, they included my slides. See, generally a child coming with a short-term fever less than 5 days, think about first is benign viral illnesses. DD for day 5 fever or day 3 fever. Can you move further? Can you move further? So think of benign viral fevers. That is benign viral URI. Generally, they present respiratory symptoms. They resolve by third or fourth day. They don't persist beyond that. Second is think about complicated viral illnesses. Serious viral infections are dengue, flu, now COVID. Then think about uncomplicated bacterial infection. That's why we asked them to show the throat to look for tonsillitis, otitis media, or dysentery. Then you think about complicated bacterial infection like pneumonia, UTI, and meningitis. You also think about tropical infections. No, in our country, tropical infection is the most predominant. Children presenting with fever less than 5 days or less than 1 week, malaria, leptospira, and typhoid. So what is your approach toward a short-term fever? How do you approach? How do you clinically approach? A child comes and sits in front of you in the OP. How do you proceed? You can't spend a lot of time, but you should have a stepwise approach. So this will be a simple stepwise approach. Okay, please attempt.
Whether the
first we check the vital signs. First we check the vital signs. Check the vital signs and decide whether the ABCs are all right. Child doesn't have altered sensorium. Perfusion is good. Breathing is normal. If in that case the child has got an abnormal altered sensorium, abnormal vital signs, the child needs to be hospitalized. First one. This is step 1. Step 2, you ask about the host. Immune compromised host is not an uncommon thing because you may have a child with a nephrotic syndrome on steroids, or maybe a neonate, or a young child less than 3 months or less than 36 months. Child may be on chemotherapy, or child with hemolytic anemia like sickle cell disease, all the come under a high risk host. They have to be again hospitalized, even though it's like a simple illness. Step 3, you look for the focus. Focus may be looking at the throat, skin and soft tissue infection, respiratory, organomegaly. You think about these conditions, these clues. And then when will you suspect dengue? When will you suspect tropical infection? My next question, when will you suspect a tropical infection in a child coming with less than 5 days fever? Tropical infection probably maybe the first thing we think, apart from systemic infection like UTI, meningitis, tonsillitis. We always think about tropical infection. We definitely think about tropical infection, particularly the present with hepatosplenomegaly and the laboratory support with increased transaminases, platelet count, low platelet count. These are all the features to suggest tropical infection. Last question is, when will you think about dengue in a child? When will you suspect dengue? On what basis will you think this could be a child with dengue?
On history, epidemic, and then with the investigations,
Correct. I agree with you. Mainly, more than symptoms and signs, predominantly epidemiological clue. Everybody started seeing dengue. This in June to February, we see a lot of cases of dengue. That is first thing you think. Second is absence of respiratory symptoms or any other focus. A child coming without any focus or respiratory symptoms. Think about the dengue. And then aches and conjunctival congestion. These are all the features to think that we may be dealing with the child with dengue. That is, Janani suggested the Fain's criteria. Janani, can you unmute and tell about Fain's criteria, Janani?
Modified Fain criteria is. Am I audible, sir?
Yes, you're audible, sir. Please go ahead.
Yeah. So, I mean, it's a good, useful clinical tool which you can apply at the bedside because leptospirosis diagnostic methods are not easily available and it takes a longer time. The MAT is not easily available and lepto-IgM takes at least 2 weeks to become positive. So this is like clinical criteria, lab criteria, and epidemiological criteria. 3 parts are there. Clinical is high. I mean, the scoring, there's a scoring, history of fever, high grade recorded temperature of 104, severe headache, conjunctival congestion, and myalgia. All this have a score of, I think, fever has got 1 and documented fever has got 1, and then headache has got 2, myalgia has got 2, conjunctival congestion has got 2, and then lab criteria, of course, the IgM MAT has to be positive, but the epidemiological is history of contact with infected water. That applies to all of us, so that has a scoring of around 10. So if you have a clinical criteria, I mean the score of around 20 without the lab, then you should suspect leptospirosis. I think I think one good thing about leptospirosis is it responds to any drug under the sun. So it responds to amoxicillin, cefixime, doxycycline, which are usually used for the treatment of any child with fever. So that is why we don't see that such rampant leptospirosis in children as much as what we saw in 2000 and 1999.
Thank you, Janani. Last question is, you mentioned about fever with rigors. I think nowadays we don't see condition present in fever with rigor. Earlier we used to have a lot of malaria, children malaria. I don't know about Koureki and government's public sector setup. Very rarely we see, maybe only 1 or 2 in the whole year. Do you still see malaria?
No, sir. Not much. We see once in a way we do get a case of malaria.
Ramesha?
We are not seeing. The last 1 year I never seen any malaria.
Low in the list. Probably earlier we used to classify most of the short-term fevers with or without rigors. We don't see malaria now. That Ramchandran lighter vein has added a comment saying that in personal life now we see Pambaram season, Goli season, cricket season like that. Thank you, sir. Okay, can we ask them to proceed further to examination?
Yes, sir. Sajita, proceed with your examination.
Big time lag, I think, between Egmore and Thiruvanmiyur.
Sajita?
Couple season.
Ma'am,
Start presenting, ma'am.
Proceed further to examination.
ma'am, ma'am, am I audible?
Yes, you're audible. Please proceed.
Proceed to the examination, please.
Your slides.
Proceeding to general
Your voice is breaking,
examination.
Sajita.
Child was awake, little dull, at the time of examination.
If you have hotspot in your
On
phone,
general
please use that. We are unable to hear your
Your
voice.
voice is breaking.
If you have hotspot in your phone, one of you can use that. That will help us.
Sajita?
Doctor, she must have left.
Yeah, she left. I think she probably. Sasireka is there, I think. No? Sasireka's name is seen here. Till Sasireka joins, yes, the PRC quote on the chat box. Till May, June, we are thinking COVID, missy only. Now the time has changed. Think about dengue, and viral pneumonias.
Even the dengue, sir, those children presenting with abdominal pain, they are deteriorating very fast.
Oh.
Because this is quite unusual the previous years as compared to this year. Because previous year, most of the dengue patient will come emergency, maximum couple of hour IV fluid or oral dehydration therapy, they will go home within 1 or 2 days maximum.
Okay.
But this time, yesterday one child night admitted, and we thought dengue initially, we did hematocrit and everything, but quite significant number of children with severe abdominal pain with vomiting, they are deteriorating very fast. Within 2-3 hours, no pulse, no BP kind of things, and leaking like anything. Once started leaking, they are leaking like anything. So
every season we learn something new from dengue. Every season.
Yes, sir. This is one learning from as compared to the previous years.
I think soon genomics will start playing a role for every disease and every infection, I think. So the host reaction is so different.
Yes, sir.
In each of this thing, the same virus, those different treatment, taking good care. In spite of that, one child crashes so badly. And also, I like the way Dr. Thangvelu insists on the epidemiology. It's very, very relevant. Actually, who you are depends on where you are and when you are.
Yes, sir.
It's really.
Yes, sir. Recently, one parent from UK came on vacation, brought the child. When I wrote about CBC, CRP, blood culture, lepto, everything, he was surprised. Why do you so much investigate? Because for a pediatrician, old diseases still stay with us. All the old diseases like typhoid, stays with us. And then all new diseases like dengue, COVID are joined. Nobody left. Previous occupants never left.
Shajita?
Yes, yes, she has joined, I think.
Please move your slides. Your screen is visible.
Ma'am.
Oh, yeah, you're
Yes,
audible. Your
Doctor,
screen is
fine
visible.
now.
Yeah, you can proceed, ma.
General examination.
Sir, can I ask her to present if the video is otherwise not?
Yeah, without video. Sajita, you can present without video.
You can just
Probably you
present the
can,
findings
you can
without the
save
video.
the
ma.
Wi-Fi. Save the Wi-Fi. Yes, Janani is biphasic.
Yeah, I think maybe using the two device, I think.
All of you sit in front of one device.
Yeah,
Yes, please.
yeah.
Do it with one
Probably.
device. ma.
Yeah, that's
Am
why
I
you have
audible?
to don't sit together, no? That so you can keep
One
separate.
device
You're
and sit in
audible.
front.
Yeah.
Or shall I ask the DAP to present?
Yeah,
Pa?
proceed.
Sajita, if you are
Yeah, you can
unable to
press it. Yeah.
log in. Okay.
I'm audible.
Proceed. Audible.
Okay. On a general examination, the child was awake, dull looking, afebrile at the time of examination. Hydration was bad. Facial puffiness was noted. Erythematous rash present all over the body.
Doctor, your screen is not there.
Can I request the DAP to present so that they can talk?
Doctor, I don't have the PPT.
Can I forward it?
Yeah, sure, doctor.
Can
Please
forward
send it to me.
Who should I forward it?
Doctor, I've put my email ID in the chat box. You can take it from there.
I'll show you. I'll tell you.
Sir, now will come to sir.
அனுப்பிச்சிருங்க அனுப்பிச்சிருங்க இவங்க I'll tell her this thing also. You can also try easily.
Post 8 at diapindia.org.
யாருக்கு அனுப்பணும்?
DAP க்கு அனுப்பிச்சிருங்க.
சார் எனக்கு மெயில் ஐடி வேணும் சார்.
Post 8 HOST8 at diapindia.org.
Okay.
Post 8 at diapindia.org. Check with the DAP person whether she's present.
DAP, do you agree with that?
Yes, doctor. This is my email ID.
Yeah, okay, please, Sajita. DAP, we were all very strict with us to send the presentation earlier, but now we are not strict with them. Sajita also can start presenting. Can start
Have you received
presenting.
it? Yeah.
Without slide also you can present. Let the slide come.
I've sent the mail.
Doctor, I'm checking.
Yeah.
Sajita, you can start your presentation, ma. Still the slide comes out, no problem.
Dr. Shajita, Sasi?
Sasikala, you can present, Sasikala.
You can start presenting. Sasikala, triple S.
Yeah.
One of you can start presenting.
One of you can present, ma.
One of you can start presenting.
Doctor, I haven't received it yet.
host8@diap.india.org.
Yes, doctor. This is my email ID, but I haven't received it. You can WhatsApp.
DAAPindia.org.
Huh?
You can send it on.
DAAPindia.org. No dot between DAAP and India.
Oh,
host8@diapindia.org.
okay, okay.
Yeah, I think.
Yeah, I made a dot extra there.
Any of Poli can send it again.
Yeah, I'm sending it, sir. I'm sending it.
Yeah, please, in case of. Triple S, start presenting.
Sasikala, unmute. Sasikala, you are, I think you are there. You unmute. Sasikala, please unmute.
Sir.
Yeah, it is visible. Yeah.
Good evening, sir. Are we audible, sir?
Yeah, audible.
Very well audible.
Audible and visible must start.
Are we audible,
Perfect.
sir?
Start.
Audible.
Yes, audible.
Okay. Examination. The child was awake, the dull looking, asymmetric fat, face, dull looking, asymmetric, hydration fat, faintness present, erythematous rash all over body was noted. No pallor or icterus or cyanosis, no edema of the extremities, no coated tongue, no petechia or purpura, no eschar noted, no conjunctival suffusion, no vital signs. The pulse rate was 90 per minute, regular in rhythm, normal in volume with no specific character, no radial or radiofemoral delay. All peripheral pulses were felt equally. Respiratory rate was 30 per minute, regular and thoraco-abdominal type. Peripheries were warm with a good pulse volume of 3+2+. BP was 160 measured in the right upper arm in the sitting position. It fell between 50th and 90th percentile for this child. Tourniquet test turned out to be positive. Temperature was 98.5 degrees Fahrenheit measured in the right axilla. Saturation was normal in room air. Anthropometry, height is 110 centimeter between 25th and 50th percentile. Weight is 25 kg between 90th and 97th centile. BMI is 21.6 and the child is obese. On systemic examination, inspecting the abdomen was not, the abdomen was not distended. All quadrants moved equally with respiration. Skin over the abdomen was normal. No scar, sinus or dilated veins noted. Umbilicus in normal position. No visible pulsations or peristalsis. Hernial orifices were free and external genitalia was normal. On palpation, abdomen was soft. No abdominal wall edema. Right hypochondrial tenderness elicitable. No guarding or rigidity. Liver was palpable 3 centimeter below the right costal margin along the midclavicular line with the smooth surface and soft consistency and rounded regular margins. It moves with respiration and spleen was not palpable. On percussion, no shifting dullness or fluid thrill. A puddle sign was also negative. Liver dullness felt started in the 5th intercostal space and the span was 10 centimeter. On auscultation, bubble sounds were heard normally. The other system examination, cardiovascular system, both the first and second heart sounds were not heard normally, no murmur. A respiratory system, bilateral air entry was present, but it was reduced in the right side infraaxillary region. No added sounds or no retractions was noted. 15, but child was dull looking. A provisional diagnosis was a 6-year-old female child with acute onset fever, with rash, with vomiting, abdominal pain, lethargy, reduced urine output, and on examination showing a dull-looking afebrile child with generalized erythematous rash and a positive tourniquet test, and a soft tender hepatomegaly, effortless tachypnea, and reduced air entry on right side. This is probably a case of dengue fever with warning signs. Ma'am?
Take over, sir. Sir, Dr. Ramesh, sir, you can take over. Okay. I'll take over until sir starts questioning, ma. Can you just mention about how you did the tourniquet test?
Ma'am, first we'll have to make a square of 2.5 centimeter on the forearm, and then we'll have to tie the BP cuff and rise it between the systolic and diastolic BP and hold it for 5 minutes. A positive tourniquet test is when multiple petechiae more than 20 are noted within the square. More than 20 is strongly positive.
More than 10 is
more than 10 is also acceptable, but it is equivocal.
What is the utility of this tourniquet test? What does it indicate to you? How useful is it?
It just indicates capillary fragility, ma'am. So
Is it very specific for dengue?
No, not specific for dengue. It is also seen in other conditions like leptospirosis,
Scrub typhus also.
Okay. Can you have any false negative tourniquet test in dengue?
If the child is obese and if the child is in profound shock, we will get a false negative results.
Okay. Is any other use for this tourniquet test?
Just such, when the child comes with the no warning signs and when you just have a generalized 3 days fever with no clinical clues, a positive tourniquet test just point towards the clinician to know that this might be a dengue fever.
Okay, that's one thing. Okay, so you will monitor the child in the OPD with this simple bedside test. Okay. You said in your anthropometry, your interpretation was this child was obese.
Yes, ma'am.
How relevant is anthropometry in a child presenting with dengue?
First of all, in an obese child, while we are calculating fluids, we'll have to take in the ideal weight for the age and not the present weight. And then obese child is more prone for going in for severe dengue because of a brisk inflammatory response, which is not benefitable for the child, but it is only detrimental.
Yeah, you're right. But what is that? What makes an obese child at risk? Why is it that? Any explanation?
They have more. They'll have more white adipose tissue, which is a reason for increased cytokines and inflammatory response.
Response for that infection.
Yeah, more of interleukin 6, 8, and CNF. Okay, fine.
Increased inflammatory response.
Okay, fine.
So the child can go in for a severe dengue.
So obese child, you're more worried and will be more watchful. Okay, fine. You said in your vital signs, you were saying about the heart rate, respiratory rate, blood pressures. What are all the positive you will have in your vital signs in this child, dengue with a warning sign? In your pulse rate, your respiratory rate, your blood pressures, what probably you anticipate?
Ma'am, you're not audible, ma'am. Sorry, ma'am.
In your vital signs, am I audible now?
Yes, doctor, you're audible.
Yeah, in your vital signs.
Ma'am, you're not
audible for us.
Shajita?
So they have to ask, use the separate device, madam. Actually, there I think so single device, 3 of them sitting there. That's a big problem now. They have to use a separate device.
I think they're using one device. I'll just confirm with them, sir.
Yeah. Ask them to use a separate device means at least we can use one
Sir, Rajendran, if they're sitting together and talk, there'll be echoes.
Yeah, that's a big.
Talking at the same
No,
time.
that's why they have to ask them to go to a separate room and they can participate.
Sajida, do you listen to Dr. Puri's question? Hello?
Sajida Banu, you please proceed. Hello?
Puri, can you repeat the question? She's available now. Unmute and ask the question. Please unmute Dr. Puri.
Sasikala?
Ma'am, are we audible, ma'am?
Yeah, one of you just have one device switched on. All the other devices will be switched off and you can talk through one device only.
Okay, ma'am.
Okay, fine. You were looking at the vital signs. What clue will you get in your pulse rate, in your respiratory rate, and your blood pressure in this child who was presented with warning signs?
With the pulse rate, that if the child goes in for in the dengue child can have bradycardia.
Okay.
And then it can also have tachyarrhythmias. And if the child had tachycardia, it means the child is going in for shock.
Okay.
Pulse pressure.
What about narrow pulse pressure?
BP.
Yes, sir.
Narrow
BP
pulse
wise, the dengue child going in for shock will have a narrow pulse pressure. So whereas in a septic shock, the pulse pressure will be wide. And also the character of the pulse will be weak, thready pulse in dengue shock. Whereas in septic shock, it will be a bounding high volume pulse, sir. So that is about BP, sir.
For a respiratory rate, there may be a tachypnea will be seen if there is a fluid accumulation in the pleural cavity, sir. If the child are having pleural effusion.
You mentioned about skin rashes. What are all the type of skin rashes you might get in dengue?
It depends upon the phase the child is, sir. When the child is in a febrile phase, the child can have erythematous, maculopapular, or morbilliform rash. And when the child is going in for a critical phase, the child can develop petechiae and purpura. And during recovery, the child can have a diffuse erythematous rash with white clearance in between, which is called islets of white in a sea of red, which is it itches, sir. Associated with it.
Good, you have covered all type of rashes. But one thing which was worried me is you don't tell about puddle sign in a child with a dengue sick child. No, that's not routinely done. It's not routinely done.
Sir.
It's also difficult to make out with the child with tenderness. And you also mentioned about hydration is fair. You have to commit whether dehydration or adequate hydration. Don't use the word fair. Fair means you are uncommitted. You are unable to decide whether the hydration is adequate or not.
Okay,
what is
sir.
the type of shock in dengue? You mentioned about dengue. What are the various types of shock based on the cause?
The child can go in for a compensated shock.
It's a general question. When you see a child with shock, what are the different mechanism or types of shock?
Sir, the child can have an hypovolemic shock, septic shock, cardiogenic shock, obstructive shock.
Okay, it's not septic, it's distributive shock. So what are the
Distributive
cause
shock.
of distributive shock?
Sepsis, anaphylaxis, and spinal shock, like neural injury. Okay,
So
sir.
what do you think? Where do you place dengue here? What is the type of shock in dengue?
It's a
Hypovolemic shock,
hypovolemic
sir.
shock. It's a capillary leak. Intravascular fluid is lost. It's a hypovolemic shock, sir.
Then why do we use inotropes or vasoactive agents in dengue?
The inotropes are given just as an interim period because there will be an inherent myocardial dysfunction in dengue
So in
itself.
addition to hypovolemia, it may be complicated by cardiogenic element in the form of myocarditis. Or if the child developed abdominal compartment syndrome, it can even present as a obstructive shock.
Obstructive shock. Okay.
That Ramesh, I think that Ramesh available.
Yeah, in examination, are you mentioned about the conjunctival involvement?
Yes, sir. We had said no conjunctival suffusion was noted, sir.
Okay. Are you looking for any other than RAS? Any particularly you look for any scar present or
Yes.
not?
Yes, sir. We had mentioned no petechiae, no purpura, no S-sharp. We had mentioned.
Okay. And second thing, you used in anthropometry, you
Yes, sir.
mentioned obese.
Yes, sir.
Which chart you followed? Based on which chart you are saying that this is obese child?
Sir, it's a WHO 0 to 18 years chart, sir.
WHO's chart is up to 5 years. Up to 5
IAP WHO chart.
IAP WHO chart, sir.
chart
Integrated.
is there.
Yes.
Yeah, or else we have a IAP chart. Okay.
Okay, sir.
So this child is really obese or overweight?
Yeah,
Obese is
27,
your
over 27 only obese.
Yes, sir.
Only 22 mentioned. So is it obese or over? That was his question.
IAP.
Sir, this BMI,
girls.
sir, this BMI value fell under more than 95th percentile for this child, sir.
In IAP chart.
Yes, sir.
It's categories as obesity only if it is about 27 adult calculation.
That's what I'm saying that
Come under
because if you
overweight
use
only.
IAP chart, very careful. There is a
Okay.
girls and boys, there is a 5 to 18 years. You should be very careful about the centile. I think more than a 75th centile, and one is more than 71st centile, the boys, to say that
Okay.
is obese or overweight. So we can
Okay.
careful that one. And
Okay,
the
sir.
second thing is, I already, Dr. Tangwell sir has rightly mentioned about the hydration status, because one side you are saying hydration is fair, another side you are saying the facial puffiness was there. And second thing you mentioned, reduced air entry on the right side of the chest.
Yes, sir.
Okay.
Yes, sir.
What about the other findings? If you are found reduced air entry on the right side, let's say, what about the other finding? Percussion, okay. Whether is any dullness is noted or not, is any evidence of the effusion or you want to say something, you have to elaborate other finding now. Simple
Sir,
reduced air entry
in
alone is
abdominal-
not enough.
Abdominal examination, percussion, we had mentioned there is no shifting dullness or
No. Just
effusion.
you told reduced air entry, no?
Okay,
Right
sir.
side.
Okay, sir. Okay, sir.
You must mention about
Yes, sir.
other
Yes,
signs.
sir. Yes, sir.
Confirm that if there is any effusion, is there
Dullness.
or not.
Okay.
Yeah,
Okay, sir.
dullness, whether crepitation, any bronchial breathing, any dullness is there or not, is simple effusion,
There was
if
no
there is any
crepitation.
associated pneumonia, we don't know, we have to mention, okay?
Okay, sir.
That is more important.
Okay, sir.
Okay, sir.
So
Then,
proceed with your presentation.
Yes, ma'am.
yes, madam.
You can say it orally if your slides are not visible.
Okay, ma'am.
You can click share slides, it will come up. Share screen, yeah.
Sir, on day 4 of illness, when the child had presented to us, the investigation done was total blood count, which revealed complete blood count, which revealed a total count of 4,000, hemoglobin 10, and hematocrit 31. Platelet was 90,000. CRP was negative with a value of 1.4. Smear for MPMF was negative. Chest X-ray showed a right-sided pleural effusion. Dengue NS1 was sent and awaited for reports. And LFT was marginally elevated. OT was 115, PT 225, albumin 3.2. Ultrasound abdomen was done considering a dengue child with warning signs. It showed right pleural effusion, gallbladder wall edema, and wall thickness of 4 millimeter, and minimal free fluid in abdomen was a report in ultrasound, sir. For this child, the treatment given was considering the child already had a right pleural effusion with effortless tachypnea. We went in for IV and the child had vomiting, not tolerating oral feeds. So we went in for IV fluids at 3 ml per kg per hour. Supportive management was given, and mother was encouraged to give plenty of oral fluids to the child. We monitored the child for urine output and vital signs. Considering the urine output of 1.5 ml per kg per hour and the child tolerating adequate oral feeds, IV fluid was tapered and stopped over the next 4 to 6 hours, sir.
Can I stop you here, Sajita?
Yes, sir.
Yeah, you presented the lab findings.
Yes,
Can you
sir.
further analyze it? You have a child with leukopenia.
Yes, sir.
Okay. And CRP
Okay.
was?
CRP was negative, sir.
Negative.
One.
Transaminases were raised. So
Yes,
which
sir.
transaminase, among the transaminases in dengue, which will be more, SGOT or SGPT?
SGPT is more liver specific, sir.
In
Dengue
dengue?
AST is elevated, sir.
OT.
So SGOT is more raised, but I think your presentation is SGOT is less, SGPT is more rough. So in dengue, mostly we expect SGOT to be raised more than the SGPT. Okay.
Okay.
So this
Okay.
looks like a tropical infection. So how do you go beyond this? Now your NS1 is still not available. You
Awaited,
have a
sir.
child with raised transaminases, thrombocytopenia,
Yes, sir.
and then can you analyze what are all the tropical infection? How do you decide that it could be dengue?
Sir, this child had a total count of 4,000, which was leukopenic, and other tropical infections we expect to have leukocytosis. And this child had thrombocytopenia also with platelet of 90,000. And CRP was negative, which is more in favor of a viral infection than scrub or other tropical bacterial infections. And the smear for malarial parasite was turned out to be negative. So considering leukopenia with thrombocytopenia and negative CRP, we take this child to be more in favor of dengue, sir.
Correct. Because if the child is CRP negative, almost all other tropical infections, malaria, typhoid, scrub typhus, lepto, everything will have a positive CRP. This negative CRP is in favor of dengue. All the other will have a raised CRP. If you have a raised CRP, but low or normal count, it more points towards typhoid fever.
Okay,
If
sir.
you have a raised CRP with the neutrophilic leukocytosis, that can happen in leptospirosis. So this itself will give a very clear clue, pointers towards a particular type of tropical infection. Probably with this you are finding, we stay with the diagnosis of dengue. So as for WHO criteria, where do you place it? Dengue with warning signs, or dengue, severe dengue, or dengue with warning signs?
Dengue with warning signs, sir.
And you started the fluid on 3 ml per kg. I just want to ask you one question. What is your objective? You want to give more fluid, less fluid?
The child is already
No. 3 ml kg per kg means what is the thought in your mind? You want to give more fluid or you want to give less fluid? Why do you choose the 3 ml per kg?
more.
More and less. I'm just asking.
What is our fluid strategy?
Initially, we'll have to give normal maintenance fluid at least for the child, since the child is not tolerating oral intake, sir.
Okay, can you calculate the maintenance for this child? 25 kg child. So 3
Yes,
ml
sir.
per kg means you will be giving 75 ml.
Yes, sir.
So what is the normal maintenance for this child?
Sir, for 65. Sir.
40, 20, 65 only.
40,
So I just
20.
wanted to say all this 5 ml, 7 ml, 3 ml criteria probably work out very well in the community, because when a nurse or in the PhD, they may not know how to calculate the maintenance fluid. It's my impression. I don't know about practice in other things. I think better in institution where we have an academic persons, and better that we calculate according to the maintenance fluid. Probably we can say 70% maintenance. So 65 ml per hour is the normal maintenance, means maybe 42 will be 70% maintenance. You can increase to 80% or decrease 60%. So I am just telling my impression of about, just got to like to get opinion from Tourniquet and Ramesh also. Rather than calculating, because 3 ml per kg, 4 ml per kg for a child with 60 kg will be a huge volume. Maybe even 1.5, 2 times maintenance. You inadvertently will be giving more fluid. So I think better to calculate according to the maintenance fluid. That will be a better practice, I think. I like to get opinion from Tourniquet and Ramesh Kumar.
Okay.
Sir, I'm agreeing with you because I am more cautious about the fluid in dengue. Okay, what Angul sir says totally is correct.
Dr. Ramesh, your voice is unclear, not clear.
Ramesh, you have to keep the mic nearby. You're not audible and very
Community
weak
level,
voice.
we can follow whatever the 5 ml, 3 ml criteria categories. But in academic institution, we should be more particular and meticulous about the fluid, because the more fluid will lead to harmful. Okay, whether it's a dengue, whether it's a septic shock, whatever the things. Okay, so very, very important about the fluid. So I am totally agreeing with Dr. Tangavelu's concept, number one. Number two, you mentioned your presentations, the child was started maintenance fluid. Okay, what about the airway breathing? You said child is a effortless tachypnea. Okay, and directly you are jumping to the circulation. What about your airway and breathing? Airway
And
breathing, supportive therapy means start with airway, start with breathing. Whether you are doing something or not doing something, we have to mention it. Okay, that's very important.
Okay, sir.
So how therapy you will offer this child, if at all maximum? You told myocardial dysfunction is part of the dengue, number one. Number two, any child with a shock, whether it's present or absent. Okay. So what about your airway breathing stabilization?
Sir,
Airway and breathing stabilization.
airway is stable for this child, sir. And breathing, the child has effortless tachypnea.
That too due to the right side pleural effusion alone.
You want to give any support? You want to give any support? Do you like to give any support for the effortless tachypnea because of the pleural effusion?
No, sir, the child did not have any distress as such, or in the form of increased work of breathing. And the saturation was also maintaining in room air. So there is no need for oxygen or for a simple effortless tachypnea.
Do you want to wait till child to develop distress and develop hypoxemia to intervene? The child is maintaining saturation because of increasing rate. Do you want to give any support at the beginning itself, or you want to wait till saturation to fall, or child to express any distress, something?
I agree with Dr. Ramesh Kumar, because a child has got pleural fluid, it is no more effortless tachypnea. Naturally, the workup breathing may be more, because if the child does not have pleural fluid, you can say that maybe effortless tachypnea usually occurs in only fever or anxiety or pain or diabetic ketoacidosis or other metabolic acidosis. So mostly, probably the child doesn't express much of intense workup breathing. Probably the child may need oxygen, because any child, even though maintaining saturation, a child has tachypnea or increased workup breathing, it's safer to start on oxygen, because their oxygen required may be more.
Okay, sir.
Instead of allowing them to deteriorate.
Okay, sir.
Okay, Ramesh, next question.
So you asked a mother was encouraged to give plenty of oral hydration. What type of fluid you will give? What type of fluid you will ask the mother to give?
It's an ORS, tender coconut water.
Okay, yeah, fine. I'm explaining ORS only. That's the most important thing, because the GI system.
We should not give any carbonated items or the sugar containing more sugar containing fluids, sir.
Yes.
It will cause an osmotic diuresis, and it will be very difficult to interpret the urine outputs, sir.
And another important thing I noticed in your triage, what is the blood sugar? Blood sugar. The
Blood sugar was 110, sir.
Are you mentioned? I don't know.
Sir, we have random
Mentioned,
blood sugar.
okay, fine.
Yes, sir.
Okay, fine. Because I have not noticed in your slides. That's fine.
Sir, the first one. Okay. Okay.
And one more comment from Professor PRC. What is the differential count?
Sir, neutrophils were 35 and lymphocytes is 57, mixed 8, sir.
So this is, do you think it is, which have any diagnostic value, differential count? Mixed or monocyte? M means monocyte or mixed? What do you mean by mixed? Okay, what is the usefulness of differential count?
So, leukopenia with the lymphocytosis with the thrombocytopenia, it's more favor in dengue, sir. Lymphocytosis with the lymphopenia is more in COVID, sir.
That way it will be useful. Leukopenia and lymphocytosis is the usual picture in most of the viral infection, including dengue, except in COVID where we have lymphopenia.
Can I ask one more question?
Yes, sir.
What is the basic pathophysiology in dengue? The basic pathophysiology in dengue fever.
Sir,
Capillary.
both the capillary leaks, sir, both the direct viral and immune mediated damage to the endothelium, so which causes capillary leaks. Third space.
Is it capillary? Is it endothelial damage or
Yes.
endothelial dysfunction?
Yeah,
Dysfunction.
direct viral causes, yes, sir.
Dysfunction.
Glycocalyx will get
It's an endothelial
disrupted.
dysfunction.
Endothelial dysfunction, because it's widening of the endothelium space leads to the capillary leak. Okay, that is a totally different from the other kind of septic shock and this one. Okay, that is why they will respond very quickly also.
Okay,
The
sir.
response is also is as compared to the other septic shock, will take couple of days. But dengue sometimes start showing recovery, they will show recover very soon. So that is very important. Okay. And
Okay, sir.
does the platelet value, it give any clue? Platelet values will give any clues?
Sir, when the child goes in for in the onset of critical illness is marked by rapid fall in platelet values, sir, along with increase in hematocrit.
What is the implication on the platelet numbers with respect to the pathophysiology and outcome?
Severity will be more when the thrombocytopenia is more.
No, even sometimes dengue child, even 1,000, 2,000, the many will recover because there are a lot of the theories or research coming up the immunological basis, because the platelet have a expression of the certain receptors, particularly 2 receptors. Okay, and one is called CD209, another one is called CD32.
Okay, sir. Okay, sir.
If expression is more, the destruction will be more. Actually, it is a pointing towards the production. Okay, because this is based on our recent research experience. We found there is an expression of the platelet receptors. Okay, they will downregulate, so the platelet will get destroyed by the own macrophage, phagocytosis. Okay, so ultimately it gives some kind of protection. That's very important.
Okay, sir.
Suppose if child have a Kawasaki disease, if you're suspecting some Kawasaki can happen, this combination of dengue with Kawasaki we see in couple of cases. If Kawasaki disease, what is the prognostic implication of the platelet count in Kawasaki disease? Dengue with Kawasaki comes with you. What are the prognostic indications?
So thrombocytosis is more common in Kawasaki, but in the late case of Kawasaki can go in for thrombocytopenia also, sir.
What is it? How it's going to help you to predict the outcome in Kawasaki? Because thrombocytopenia in Kawasaki.
Thrombocytopenia has a poor prognostic indication than thrombocytosis, sir.
Yeah, because we should be very careful about for the coronary involvement, because they are very important because both are different spectrum. One will so we should be very careful because dengue with Kawasaki quite common. And second thing is dengue. Do you want to think any other complication dengue can cause?
Bleeding, sir.
Other than capillary leak. Other than capillary leak. No. Dengue with Kawasaki or dengue with any other condition, you do want to think about it?
COVID. Dengue. COVID, sir.
Okay. Next, any other thing?
Dengue with along with the other tropical fevers also, sir, like scrub.
Fine. Next, dengue itself can trigger secondary HLH.
Okay, sir.
Okay, you should be very careful because that is because your ferritin and the fibrinogen level will help you. Okay, because the the treatment will totally differ.
Okay,
dengue with Kawasaki, dengue with secondary HLH, otherwise called macrophage activation syndrome, someone say, the treatment will differ and they will respond so nicely. So it's very careful. Okay, how is the treatment going to differ? Any idea?
For dengue with HLH, sir.
Dengue with Kawasaki.
Dengue with
Kawasaki?
Dengue with Kawasaki, we'll have to start the child on IVIG, sir.
Okay.
And then along with the aspirin,
If the platelet count is more
Okay.
than
Dengue with secondary HLH?
we'll go in for steroids initially, sir.
initially, we
for-
have to try to treat
Treat the underlying cause.
underlying cause, sir.
If any
Yes, sir.
secondary cause of HLH, we'll have to treat the underlying illness first. And then we'll have to treat the child if with the steroids. Sir.
Steroids, sir.
Yes.
Dexamethasone.
Why? Why steroid? What you want to target steroid? How is steroid going to help?
Sir, it will suppress the hyperinflammatory state, sir.
What is it called? Cytokine storm.
Cytokines. Okay.
Yeah.
Yes.
Activation of the T cell activation, macrophage both will lead to a
Yes,
lot of cytokine storm. So if we want to suppress that, so we need a Dexa. Okay.
Okay.
That's
Okay.
because prognosis wise, they are all really good as compared to the primary HLH. Okay.
Okay. Okay. Sir.
We just started telling about the difference between septic shock and dengue shock. We interrupted. Can you complete that question? How will you differentiate? Because the child comes in shock. In
Yes,
dengue
sir.
shock, probably you'll have to give restricted fluids.
Sir,
And septic shock may have to give more fluids. So how do you clinically different? Clinically or with the basic investigation you will differentiate?
So clinically, the child will be afebrile in dengue shock, sir. And septic shock, the child will have high grade fever. And then perfusion wise, the CRT will be prolonged in a dengue shock with the weak peripheral pulses, and the pulse pressure will also be narrow. In a septic shock, the pulses will be bounding with a wide pulse pressure and a flash CRT. And investigation wise,
Few other things. There will be tachycardia in septic shock, but in dengue,
Relative
relative
bradycardia.
bradycardia. Relative bradycardia. Sensorium will be preserved in dengue till they go in for hypotensive shock, but in septic shock, early loss of. And if you get a platelet count, probably that will be helpful. And so usually bleeding tendency is more commonly seen in dengue than septic shock. And we started about low volume. Generally, we give 20 ml per kg fluid boluses. Tell me some condition where you will use 10 ml per kg fluid boluses. You are giving lesser fluid volume. Apart from dengue, some more condition where you will use only 10 ml or 5 ml per kg.
So
Low volume boluses.
Sir, for a cardiogenic shock, we can give for 5 ml per
Cardiogenic shock.
to the 1 hour.
Further. Another D. Another D. Dengue like another D. DKA. DKA. Then SAM. SAM also you don't give large volume bolus, only 10 ml per kg. What are the cause of bradycardia?
Dengue, typhoid.
What are the mechanism?
Mechanism of bradycardia and dengue.
I'm not sure. Maybe
Sir,
because
that
of
is
myocardial impairment. Maybe
myocardial
because of
edema.
Myocardial
edema.
edema.
Ramesh, any other reason? Mechanism of bradycardia and dengue. I think it's probably
Because of
myocardial impairment. Or any other.
Myocarditis, yes, sir.
Usually myocardial involvement in dengue.
So the myocarditis is there, and even the recent AHA guideline also changed for even septic shock also. They are saying 10 to 20 ml. The previously it was upfront 20 ml per kilo. Now they are saying 10 to 20 ml because of the lot of concern about the fluid overload. Because of whatever fluid you can give, okay, only the hemodynamic response is only short time. Okay, so finally we will go and land up in the third space accumulation and leaking. So that is why Sari's asked right question. Sometime may require your vasoactive therapy in the first hour itself. Okay.
Okay, sir.
Yes, Ramesh, we were using everything overuse in life also.
Yes,
We were using Pepsi, Coca-Cola earlier, now it's stopped. We are using mobile phone, probably time may come that we may not overuse it. And Dr. Ediler has suggested that one cause of bradycardia is edema around the SA node. That is one reason, probably one of the concepts, one of the postulates. You have not been asking questions. Sorry.
That is why, that is the reason this focus, the point of care ultrasound at the bedside is like another stethoscope for us, particularly in the academic centers.
Focus.
It will help tremendously to guide the fluid therapy in critically ill child if it use it properly. It's very easy. These are the additional. I'm not saying it's always standard, but it's going to standard of care. Okay, so there is no doubt about it in future.
Your
Yeah.
questions.
Sajita, what is the best monitoring you would like to do in a child for whom you have started some IV fluids? One single.
Urine output, ma'am. Urine output monitoring, ma'am.
Yeah. How frequently
Any
would
other
you want?
factor which will alter it, Sajita? The child has
Sir,
got shock but has got more urine output.
Sir, hyperglycemia,
DK.
sir, an undiagnosed DK.
Correct.
sir.
In fact, last
DK.
week we had the same problem. A child admitted dengue,
Yes,
and
sir.
then we were very happy the child is voiding urine 4 ml, 5 ml, 6 ml, 8 ml. By day 3rd or day 4th only, we could land upon the diagnosis of DK. So persistently, if the child is losing more, passing more urine, please check the blood sugar, because there may be a stress hyperglycemia, or mother may be giving more orange juice and other juices. So if there is increased output, better you also check the glucose, just not to miss hyperglycemia.
Okay, sir.
How did this child progress further, Sajita?
Sir, the next day, the day 5 of illness, child was afebrile for 2 days. No further vomiting or no bleeding manifestation. But on assessing, the child had a further drop in sensorium. The child became voice responsive, lethargic. There was no signs of seizures. The tone and posture was normal. Airway was stable with no added sounds or no retractions, no signs of increased work of breathing. Bilateral air entry was reduced still on the right side. And heart rate was tachycardic at 145 per minute with no murmur, no muffling of heart sounds, cool peripheries, and CRT was prolonged, and pulse volume was reduced with 3+1+ with a narrow pulse pressure BP of 180. Liver span was the same 10 centimeter. So the physiological status of the child was the airway was stable, breathing and effortless tachypnea. Circulation, child had a compensated shock as evidence with tachycardia, narrow pulse pressure, and cool peripheries with 3+1+ pulse volume. And the child was lethargic.
How did you progress?
And the investigations for this child on day 2 showed a further drop in total count. Hematocrit increased from 31 to 38, which is a more than 20% increase from the baseline. Platelet dropped further from 90,000 to 82,000. Basic RFT showed a marginal increase in creatinine, and electrolytes were normal. OTPT was also elevated. Lactate was also elevated with 4 millimoles per liter. Calcium was normal, and ABG showed a compensated metabolic acidosis. This child was managed initially as a dengue with compensated shock. Airway was stable. Breathing was managed. Respiratory support was given. O2 with NRM. IV fluid 10 ml per kg bolus crystalloid NS was started over 1 hour. After 1 hour, the repeat hematocrit did not show any improvement. It actually increased with a hematocrit of 40. No improvement in volume status. Urine output was suboptimal at 0.5 ml per kg per hour, and the narrow pulse pressure persisted. So we decided to go in for a second crystalloid bolus, the NS 10 ml per kg for the next 1 hour. And reassessing the child, the hematocrit was stable at 40, and BP was falling with 90 and persisting narrow pulse pressure. Urine was still suboptimal. There was no improvement in volume status overall, but the child developed worsening of respiratory distress with new onset CREPS with increased work of breathing, and the liver span also increased it from 10 to 12 centimeter. So considering this, the child respiratory support was stepped up. The child was connected to BiPAP, and low dose adrenaline at 0.05 micrograms per kg per minute was started, and the fluid was stepped down to maintenance fluid. And bedside screening echo, we have planned to decide on the further boluses after a bedside screening to rule out myocardial dysfunction and to see the IVC, ma'am. Our bedside screening echo showed a myocardial eyeballing technique. Myocardial dysfunction was found. No pericardial effusion, and IVC was distended.
So since the child was on inotrope with the BiPAP, we had to monitor the child meticulously, but the child had no further hemodynamic deterioration, no worsening distress. So the child was maintained in BiPAP itself over the next 4 hours with the low dose adrenaline support. And at the end of 4 hours, child became hemodynamically stable with the urine output improved to 1 ml per kg per hour. And the respiratory distress also significantly reduced. So the respiratory support was gradually weaned off to HFNC and NRM and off O2 over the next 12 hours. Adrenaline was also tapered and stopped over the next 6 hours, ma'am.
So Ramesh, sir.
Yeah, can you go? Yeah, thank you. Yeah, fine. Yeah, you triaged worsening. What could be the reason or pathophysiology for this worsening?
So the child is having ongoing capillary leaks, sir. So the child is going in for cool peripheries with the increase in peripheral resistance. So narrowing of pulse pressure, sir.
Increase in peripheral resistance. No, that cannot occur in dengue.
Right.
Oh, correct. Okay.
Yes,
Okay.
yes.
No.
Of course, capillary leak is related to the peripheral vascular resistance. This capillary leak is mainly because of the morphological damage to the
endothelium.
So a child was admitted. Okay, what are the key parameters you will monitor to detect early? Okay, like this, you can pick up very early. Key clinical parameters and key clinical laboratory parameters. Monitoring.
Bedside heart rate, pulse volume, BP, the urine output, laboratory hematocrit.
What about AVPU? Level of consciousness.
Level of consciousness. Also.
Pulse pressure.
Pulse
You are
pressure.
always missing the pulse pressure.
Pulse pressure.
Number 1. And number 2, okay, you are picked up. This is the tachycardia with compensated shock. Fine. Next slide, please. So you mentioned compensated metabolic acidosis, number 1, and lactate is 4. Okay, that means, lactate is 4. That means there is a anaerobic metabolism is there. Hypoperfusion is there. Global hypoperfusion is there. What about the chloride and whether this metabolic acidosis is high anion gap or normal anion gap or hyperchloremic metabolic acidosis? Because metabolic acidosis simply don't say compensated metabolic acidosis. This is incomplete.
Yes, sir. Sir,
What is
this shock due to hypoxia and anaerobic metabolism and
no
hypoxia.
You are saying that SpO2 is throughout, the SpO2 is fine. Suddenly, how its hypoxia is coming up?
You mean hypovolemia or hypoxia?
Hypovolemia.
Hypoperfusion, global hypoperfusion.
Yes, sir.
He wanted to check whether Ramesh is alert.
Sir, this is a wide high anion gap acidosis, sir.
Okay.
And we should mention about the chloride also, sir. If the child has been, if it is a hyperchloremic metabolic acidosis,
how will you define?
Sir, the
hyperchloremia. How will you define hyperchloremia?
Chloride level of more than 110, sir.
No. Is there any relation with sodium?
Sodium.
Blind level is not going to help you. This is relation with sodium. Sodium and chloride ratio is very important. You have to say that anything ratio is more than 0.75. Okay, it's called hyperchloremia. It's always related with sodium. Why it's so important? Why it's so important?
Sir, if we are missing the hyperchloremic metabolic acidosis, then the child will, the choice of fluid will also differ, sir. And the child will also be persistently in shock if we are missing this hyperchloremic metabolic acidosis, sir.
Simple.
Thanks, Ramesh. I also didn't know the correct definition of chloride hyperemia.
Yes,
it's
chloride is always
0.75
linked
of
with sodium
level. Thank you for that. hyperchloremia is supposed to damage kidney. That's why everybody thinking chloride is a villain. Causing
And
renal
second
damage.
important,
That's why they go for. Is there any alternative concept brought in?
that's why I'm asking, sir.
What is
Because,
the sodium and chloride content in normal saline?
that's why I want.
154.
1%. Sodium content in normal saline.
154 milliequivalents, sir.
Chloride.
154 milliequivalents, sir.
Ringer lactate. Sodium content.
Sodium content is 130, sir, and the chloride of 101, sir.
Chloride is
110.
not there in ringer lactate. No, okay.
I mean,
Okay. So that's why, is there any alternative concept brought in? Because of the chloride, we can't reduce the sodium level because you have to give isotonic fluid. So you can't reduce the sodium below 140 or 131 as in ringer lactate. Was there any alternative concept introduced in the form of fluid management, or any other fluid is available where you have a choice of relatively normal sodium but low chloride? Is there any fluid available? What is that fluid called?
Hartmann solution, sir.
Okay, I think maybe in private market is available as a solution osmotically. Electrolyte balance electrolyte solution is available. Where
Balanced
sodium
salt
balance
solution.
electrolyte solution, where the sodium level is 140 but chloride level is on par with the serum.
Okay,
98. So it's called osmotically balanced electrolyte solution. Commercially available is in different names is available, but that's why people have started using balanced electrolyte solution than normal saline. But there are studies for and against to say whether they are beneficial or not.
Okay, sir.
Okay. In addition to this acute kidney injury, okay, what is the other problem with hyperchloremia with connection to the metabolic acidosis? pH, as you might think about that pH will be normal, improved, but bicarb never improved. We will go with MAD. Okay, why bicarb is keep on low, but pH is fine.
Okay.
Because mostly we ignore the chloride.
Chloride. Okay.
Okay, if body is retaining one chloride, okay, the bicarb has to go out. Body will not try to retain both. Okay, so very important. Okay, body will kidney will such a way that to maintain electro neutrality towards this. That is one important things.
Which condition the hyperchloremic metabolic acidosis is a problem? Which condition you are managing shock or dehydration? In which condition hyperchloremia is the problem?
Dengue and DK.
Look at the poly and tell.
So solitaanga, sir.
Diabetic ketosis.
DK.
Because we are using saline more, so
look at
we
me
should be
also.
very careful.
No problem.
We can very careful about these things. Unless otherwise his kidney is fine, there's no issues. Okay. And what could be the baseline serum creatinine or GFR in this child? How you will calculate? Simple thing only, bedside.
So bedside Schwartz formula, sir.
How will you calculate? How will you say that whether this 0.7 is could be the baseline serum creatinine or something else? How to calculate?
0.4 into height divided by creatinine, sir. It's a Schwartz formula, sir. It gives the bedside GFR.
Bedside modified Schwartz formula 0.413. Okay. You assume is the baseline clearance is 100 or 120 whatever way. You reverse calculate, then you can label the baseline creatinine. From that, you can compare the creatinine, because this is another ignorant, because we often will ignore this one, because kidney is the major organ will get affected in any hypovolemia. Okay, even small change in creatinine, because once nephron is destroyed, it won't come back. Once nephron is numbers are become low, 10 become 8, the child become 8 nephron throughout the rest of the life.
Like neuron, like
neuron. Even neuron has some concept of plasticity is there, but in nephron, no kind of
neurons have regeneration.
Neuron is here, some kind of concept is there, but its nephron is not no such a concept. So please careful about give the attention of the creatinine also is very important. Okay.
Okay, sir.
And next slide, please. Can you put the next slide? You started O2 through NRM. Okay. How will you choose the flow of the NRM in this child? how will you choose the flow of oxygen, okay, for this NRM in this child?
Sir,
Or even in general, how do you decide the flow?
In
How much
general,
flow you will keep?
in general, tell me what
How much
principle
flow you will
adopt?
keep?
Flow
rate
to
of
decide
oxygen.
about the flow.
So
So we'll
high
have to
flow
start
is
so we'll have to start with the 10.
Do you want to
Number or
fine tune
something
something?
else?
6 to 10 liters per minute.
No, you decide a number or some other factor, you look at it.
Some other factor. You want to
Not numbers.
Reservoir bag should be inflated.
Fill even during inspiration should be distended even during inspiration. That is the optimum flow of, generally it may record 10 to 15 liters. But ideally you decided by the persistent distension of the reservoir during inspiration.
Okay.
Probably,
addition to the
Ramesh,
reservoir.
this is the answer you expected, or?
Yes, sir. In addition to that, I want to expect. I am expecting one more answer. And what is your target in NRM? One is you want to maintain the bag flow. Okay, what is the target? Why you are starting NRM? This child is shock. Why you are starting NRM?
The child is in a compensated shock. We have to give a FiO2 of nearby 100%, sir. In NRM, we can give an FiO2 of almost 95%, sir. So we give with through NRM, sir.
Because previously the child is SpO2 is saturation is normal. Why do you want to give oxygen in compensated shock? Saturation is normal.
So the shock leads to anaerobic metabolism in the tissue, sir. So we'll have to supplement oxygen to
Because of
saturation
this
is normal,
there is
na?
a hypoperfusion that will causing the anaerobic metabolism that will worsen the condition of this child. The child will prone for bleeding and because of this persistent hypoperfusion and acidosis. So
In shock, our primary myocardial primary duty is, what is it? Supply and utilization. In normal child, the utilization, the extraction is independent of supply. But in shock condition, it becomes dependent on the supply. So our duty to ensure to give the supply. That's like through NRM and everything. Second, in NRM you start usually double the minute volume of the given child. At least that much flow should be given. Double the minute volume ventilation. That is the another things. Okay, we should be keep it these two things while starting NRM. Otherwise, no use. This is the basic difference between the shock in children versus adult. Adult have a reserve. Okay, but in pediatrics, our aim of the shock management again to bring the child, the supply and extraction become independent of the what is it supply. Okay. So the extraction and the utilization should become independent. Okay, that's our end point of the shock. Okay.
What about NRM? What is the problem with NRM? When you start on NRM, there are some problems. What are the problems? Because it may maintain a good saturation, it won't, hypercarbia may be missed.
Okay.
Child may show a saturation of 100, looking at the pulse oxygen monitor, we'll see happy about it. But if the child shows any change in the level of consciousness, hello? If you see change in the level of consciousness, you should think the child is probably hypercarbia because respiratory failure has got two components. One is hypoxia and hypercarbia. When you give large amount of oxygen, naturally oxygen will be maintained, saturation will be maintained, but hypercarbia may be missed. So whenever you put a child on NRM, you should carefully assess the level of consciousness. Also, if the child is level of consciousness dipping, you should suspect that child has got accumulating carbon dioxide. Look for other features of respiratory failure. It's a caution you should follow.
What are the other parameter? Clinical parameter you will closely monitor when you are giving fluid or bolus. Okay, in septic shock, any child of shock.
Liver span.
Closely
okay. What is in addition to the liver, because liver span is the last thing to develop.
Sir, we'll have to look for any worsening distress, sir, any new onset crepitations, and then the worsening of distress, sir.
Crepitation will be relatively as compared to the liver span because of the increasing in extra lung volume, okay, lung fluids, okay.
Fluids, yes, sir.
And outside the
Okay.
interstitium will accumulate, the crepitation will come first. Okay,
Okay.
then distress will come. Then
Come,
your
okay.
liver will enlarge. Okay.
Okay.
And
Okay.
finally, only SpO2 going to fall. Okay. So very
Okay, sir.
careful that.
Okay, sir.
Next slide, please. So that's a screening echo done by yourself.
Yes, sir. We PGs are trained to do screening echoes and PICUs.
Yes, I want to
Congratulations.
appreciate.
Feel so
That's what
happy
I want to
about that.
appreciate. That's why I'm asking very particular this question. I want to appreciate this that incorporation of this focus thing in the curriculum. So I'm happy to. That's why I'm so happy.
Ramesh, if you look at the Ramesh, if you look at a stethoscope invented by Lamarck, it closely resembled focus also because it's a cylindrical one, almost resembles the probe of the ultrasound machine.
Really good, sir. Good to see. Really good to see that they are saying. You mentioned IVC distended. Okay.
Yes, sir.
What do you want to convey?
Sir, we'll have to be cautious in further boluses of fluids, sir, because the not merely the IVC.
What IVC
Sir, we have
parameter
to
you want to look?
in a spontaneously
Collapsibility
bleeding
index.
child collapsibility index, sir.
Very good.
Yes,
When
sir.
you will measure, what about the ventilated child with the totally paralyzed?
Distensibility index in a ventilated child, sir.
Okay, what is the problem with this IVC index? Because you are happy to learn about this IVC index. Okay, I'm happy. At the same time, you can know about the flip side of the coin.
Subject, it's very
there is already fluid leak, sir. So the intravascular volume is not rightly assessed by the IVC because there is fluid leak.
Take home. I want to convince. The intention is don't go with single values.
Okay, sir. Serious.
Put it together. Put it all the clinical parameters: heart rate, pulse volume, blood pressure, and trend. Simply don't treat with single, like IVC is collapsing. I am pushing fluid. Don't do this. Okay. Don't treat with single. That's the take home. Okay. How is BiPAP going to help this child?
BiPAP will deliver PEEP. So this child has myocardial dysfunction, sir. So BiPAP, a minimal amount of PEEP will be delivered, which will be helpful for the myocardial dysfunction. And also it is a non-invasive mode of ventilation. So better, ideally we should intubate any child in dengue with cardiac dysfunction. But since there are a lot of problems involved with mechanical ventilation, it is better that we try a non-invasive mode of ventilation before going in for an invasive ventilation.
How does ventilation helps in the correction of shock? How does ventilation helps in the management of shock?
PEEP. So this PEEP helps in pushing the pleural edema.
I'm not asking mechanism. In what way it will be helpful?
Mechanism. What way
it will be helpful to the management? There are a lot of components in the management of shock. You're right. There's a mechanism. How does it?
Mechanism you are correct. Whatever you are saying. But
how does the ventilation help in the shock management?
What happens to the
Reducing the oxygen
myocardium?
consumption. Reducing the oxygen consumption because for respiration,
the workload,
reduce work of
oxygen. You take out one function so that the oxygen consumption is diverted to vital organs like brain or kidney or liver. That is the purpose of taking over the ventilation.
Consumption. Okay, sir.
You ever observed before starting ventilation, whether invasive or non-invasive, after starting ventilation, you ever observed the waveform of SpO2? Waveform of SpO2 before the shock child with respiratory distress, the waveform of SpO2 before ventilation, after ventilation.
Sir, before ventilation, it will be a small amplitude.
Practically.
Yes, sir.
No. Do you ever observed? If you observed, you will get answer for what Thangavel sir explained. You next time, please try to observe. You will get answer what Thangavel sir is told. No, you will understand the concept. Okay. Please don't ignore the waveform of SpO2. Okay. It will also help supplement you. Okay. The respiratory variations supplement you. The moment you intubate or moment you support adequately, the waveform become more uniform. Because you took away the work of breathing. Child is working so much. You took away. That's another thing. Okay.
Have we heard about a terminology called Perfusion Index? Because I
Yeah,
think now
perfusion.
I'm very happy that public sector hospitals are getting good devices. Like I think you have a special device where you can measure the perfusion index in the pulse oximeter. Do you know what is meant by perfusion index?
Yes, sir.
What is the usefulness?
Sir, it should be more than 0.5, sir. If it is less than 0.5 means
What's it? What do you define? How do you define perfusion index? The ratio between the pulsatile flow and the non-pulsatile flow. Generally, it's 0.02 to 20. So it is an equivalent of the pulse volume. I used to feel that half of my life I spent on feeling for the dorsalis pedis pulse, whether it's felt or not. So this will be probably a indirect replacement to confirm our pulse strength. We're able to identify the pulse strength. It's an indirect or an subjective objective measure of the pulse strength. Perfusion index maybe probably it may be helpful in assessing the pulse volume better.
okay.
Even my
Supplementing to
my
the
first
clinical.
assessment also.
Supplementing the clinical assessment of the pulse.
Even whenever I go to the sick child, anyone says SAC, my hand directly go to the dorsalis pedis. If that is good, the rest of the pulse volume will be good.
So the single most clinical sign which will completely reassure is the dorsalis pedis. A strong dorsalis pedis, you are able to feel irrespective of the PCV, platelet count, whatever that comes. There's one single this thing probably will reassure us that child is not very bad.
Okay.
Okay, the child have a narrow pulse pressure throughout this 20 millimeter only is maintaining. Now you started inotropic support and respiratory support both. Okay, how it is going to affect your hemodynamics? What about the subsequent blood pressure monitoring? Do you observe any change in the pulse pressure?
Yes, sir. With further, since we had supported the myocardium, there was no worsening in distress, and the hemodynamic status also improved with the low dose adrenaline support. So gradually the narrow pulse pressure resolved for this child. The final BP at the end of 4 hours of adrenaline support was 170 for this child, sir.
Because why I'm asking, okay, how the myocardium will receive the blood supply? Which cardiac cycle?
Diastole.
Diastole, sir.
Only diastole?
Diastole.
That is only left side of the heart. What about the right side of the heart? Both systolic and diastolic. Both components contribute. Very careful, number one. And why I'm concerned about this pulse pressure? That means I want to say, what is organ perfusion pressure? What is organ perfusion pressure? Because we want to ensure the vital organs perfusion, no? So what is organ perfusion pressure? It's nothing but is the mean arterial blood pressure minus central venous pressure, CVP. NAP minus CVP, but we are not mentioning. So the other way is you have to always don't only stick to the pulse pressure. Please kindly mention about your mean BP. Calculate from this also. Okay. Always very soft patient, systolic, diastolic, mean arterial BP, and pulse pressure. So these 4 parameters to monitor. Okay. If you have a CVP, then it's fine. Otherwise, no issues. But I'm saying this is possible at the bedside. That's what I'm saying. Okay.
Okay, sir. Okay, sir.
Coming down to the ground level, a child is expected to improve by day 7 or day 8 in dengue. We are looking for that day 7 or day 8 for the child to improve. If the child does not improve, worsen, or develop fever, what are all the possibilities we'll consider? Clinical possibilities.
Sir, the child
co-infection should be suspected. Secondary bacterial infections can be think of, sir. Or the child can go for secondary HLH.
Or if the child continues to be in hypoperfusion or shock, an underlying undiagnosed dyselectrolytemia, acidosis, could be the cause.
Hypercalcemia, good.
Uh,
And you also consider simple reasons like even a thrombophlebitis as a cause.
Yes, yes.
But also, these are all the reasons. Or hyperferritinemic HLH, which that's what you are going to discuss now. No?
Yes, yes.
So proceed with the slide. I think we have
Yeah,
only
next
short
slide.
time. I think 5 or 10 minutes time.
Yeah, quickly
Complete.
summarize your slide.
Okay,
Next few
the
slides.
next day of illness, the child who had previously been afebrile for the past 2 days again started developing high-grade fever spikes. On clinical examination, hepatosplenomegaly was there. This spleen was on a new onset, palpable 2 centimeter below the left costal margin, which had enlarged along its axis, and it had a smooth surface, and it was not tender. And investigation wise, the total count had actually increased from a leukopenic to a leukocytosis, and hematocrit has normalized from 38 to 30 for this child. Platelet was still in declining trend from 80 to 44,000, and there was increase in liver parameters. The OTPT had become significantly elevated, more than thousands both, and lactate was still elevated for this child. So, considering co-infections and secondary infections, we had again sent the child for CRP, ferritin, triglycerides, and LDH, which all turned out to be elevated for this child. CRP was positive 20, ferritin was more than 10,000, triglycerides 750 milligrams per deciliter, LDH was 690, ESR was also elevated for this child. Scrub serology, entry culture, BACTEC, secondary infections. Empirical antibiotics were started. 3rd generation cephalosporin and doxycycline were started for this child, ma'am. And so in a 2 days time, the investigation sent were turned out to be negative, both scrub, urine cultures, and blood cultures. And so since we have ruled out other infections, we have more points favoring dengue with secondary HLH, considering the high-grade fever and new onset spleen. This child had fever, splenomegaly, cytopenias, both hemoglobin and platelet had showed decline. Triglycerides were more than, this criteria was fulfilled. Triglycerides were more than 265 and ferritin was more than 500 nanograms per ml. So considering secondary HLH for this child, we had given injection dexamethasone 10 mg per meter squared for this child. And since other infections were ruled out, antibiotics were also stopped. 24 hours after starting steroid, the child became afebrile. On day 9 of illness, the child's sensorium significantly improved, no further shock. And total count had normalized, hemoglobin of 11, platelet had improved to the normal level, 1.7 lakhs. Liver parameters had started improving from thousands to 300 and 400s. Ferritin also declined from more than 10,000 to 6,000. LDH triglycerides also showed improvement. And this child responded well to dexamethasone, as evidenced by resolution of fever, recovery of blood counts, and resolution of organ dysfunction. As a result, dexamethasone was stopped after 5 days for this child for a total duration of 5 days, and child was discharged well on day 14 of illness.
I really congratulate you for a success story of the patient, as well as a wonderful presentation. You were all very crisp in your presentation, except the problem with the Wi-Fi. Otherwise, your presentation is wonderful, covered everything, and you answered most of our questions. I really learned a lot from all the triple S, the Ramesh, and the Pori, and everybody. Last one question. All of
Yes,
your
sir.
final year students or
Yes, sir.
final year MD students? Okay.
Yes, sir.
I'll ask you a straight question. The last 3 years, how many times you would have seen a peripheral smear?
Sir,
How many times you have seen a peripheral smear? How many times you are able to make an impression about a peripheral smear? Are you in the habit of going to the lab to see the peripheral smear?
yes, sir. We see. Yes, sir.
How many times in the last 3 years? Just a number. As just a teacher, I want to know about it.
Sir, around 8 to 10 times.
10 times only. How many peripheral smears are done in ICH? Please. See, we are in a clinic, pediatrics mainly clinical, but you have to extend to X-ray chest, to ECG, and peripheral smear or urgent CT. The peripheral smear is one of the beautiful modality, simple modality to diagnose many diseases. I have 1 or 2 occasions, I have seen a child like dengue turned out to be leukemia. I have seen a child, sometimes you can see a child with dengue, you can differentiate from from scrub typhus by looking at lot of platelet aggregates. It will be very, very useful one. Please develop the habit of seeing peripheral smear at least once a week, every Friday or every Wednesday. Someday fix it up. Tell your junior colleagues also, ask them to go to the lab and see a peripheral smear, get acquainted with that. It will be very, very useful when you go out of ICH, you go to peripheral centers. It will be a very useful one.
One last question.
Thank you very much. I think I'll Ramesh and Poor here express your
Yes,
comments.
really wonderful presentation. For one last question, but I'm totally agreeing with Dr. Thangavelu sir. I'm also asking same to my JR here. Is it bone marrow examination is mandatory to diagnose HLH?
No, sir. Not when we are
in dengue.
secondary HLH. No, sir.
No, generally, secondary HLH bone marrow is not a mandate. That's why I want to say. Okay. Otherwise, it's good, good presentation, and happy to see that. I am so happy and really enjoyed that this session, particularly with the focus, the echocardiography oriented, incorporating the curriculum of this one. I hope you will also learn about this lung ultrasound also. B line, A line. Simple B line is enough to say this fluid overload status. Simple, only one enough to. That's why I hope you will learn. Okay, because Dr. Pulai Madam is there. So definitely you will learn from these things from your ICH. Okay. Thank you and all the best for your final year exam.
Yes, thank you, sir.
Best wishes for your examinations.
All the
All
best.
the best. All three of you did very well. I'm happy about it. Sir, for Dr. Ramesh sir's query, yes, sir, we have been training our PGs to do lung ultrasound as well. So they're getting trained. Our fellows are doing a good job of
Really good,
training
ma'am.
them and looking up these cardiac parameters and lung parameters as well. It's very useful. I think they will soon start doing it on their own, sir.
So that's really appreciating, man.
All the alumni of ICH feel so happy about the facilities available and the skill
sir.
acquired by the current PGs than what we were. Thank you very much for that.
Yes, sir. I still remember those days when we used to have a centrifuge machine in the corner of ICU.
Yes, doing
Every time
hematocrit
we do
10
the
times for a
hematocrit
patient.
there is only tool available other than the clinical parameters to treat dengue those days. So
One
I think
request is what Thangavelu said. While we
Please
can,
stop slide sharing.
while we are going for ultrasound examination, etc., don't forget peripheral smear study. It's very important. I wish ICH at least with Madam Pushpa emphasizing, I think that culture should go on. Similarly, CSF examination and gram stain, it's very useful.
Yeah.
The CSF examination delay will make your cell will degrade. Okay, if you
Yeah.
go immediately and examine, you will get lot of cells. Otherwise, if you send to lab, you can wait. You will miss the main.
Next day.
ரகு அவங்க உட்கார வைங்க இதை முடிஞ்சு மீட்டு.
Yeah, PRC sir. Yeah, Dr. PRC sir is there. Dr. PRC sir.
Sir, I don't have anything to add. Thank you. Thanks for a wonderful discussion. And thank all the people involved in ICU care, day-to-day care, and bringing out. We have been doing a lot of things. Luckily, we are getting patients all right. But we understood the scientific basis of many other things by the discussion we had with Professor Thangavelu, Dr. Ramesh, and Dr. Puragi. So the PGs did a wonderfully good job. Okay, they were very methodical, they were very confident, and they were able to explain. And the best part is they had done all the things by themselves in this child, which is icing on the cake. So that is the one which really showed their the confidence and the way they have tackled the questions. So all the best to all the postgraduates who are exam going and take away all the good things, good learning points. Unfortunately, we do not have much of ICU discussion and other things, except probably the MGR University, probably you are having some ICU rounds. Other thing, it's probably not there. So if it is there, it's a good thing for you. Please maintain it. All the best.
Thank you, sir. That's Janani Shankar. Dr. Janani madam. Yeah.
She was there.
Yeah, he's. Ellerasi madam, please.
Sir, good evening. It was a wonderful presentation, sir. Sajita and Go, the case presentation and discussions went on well.
And it is very nice that they are able to do the echo as a point of care test in ICU. But now NHM Chennai, they have agreed that all medical colleges, pediatric ICU will have one echo with ultrasound, and they've sanctioned, already tender has been floated. So all the 35 medical colleges, pediatric ICU, which will be coming soon, and most probably by January it will be established, will get one echo with ultrasound. So everybody has to be trained in echo, bedside echo. So most probably after now that COVID and going off and dengue coming up so much, I think after now we will start, they peripherally also they have to start training for this, just not in ICH or the main hospitals. And well taken, Thangavelu sir, your point that everybody should know the peripheral smear. I remember how you used to 30 years back see all the peripheral smear yourselves. Nowadays we leave it to the pathologists. We will start doing it. I mean, we have to see, let the pathologist see. We do. And one Dr. Kalpana picked up leukemia in a suspected dengue 3 years back. So I think that point is well taken, and a wonderful presentation. And thanks for the moderators, trainers, and students, and all the best. Thank you.
Thank you.
Thank you, madam.
This is time to start DM course in ICH, sir. I think Purnima to take care of.
We have presented, sir. We have presented. It's we are waiting for that. Yes.
Yes, madam.
Hopefully by next year we'll get it.
Right
Yes.
place.
Yeah.
Yes,
Right
yes. We
place
were talking
to-
about it today also with Puvargi and me. We are planning to. I mean, we have already presented to the university and DME. It has to get forwarded, sir. The file is still in DME.
Cellular and Puri, we feel like applying again for government service.
So madam is the
We want to retire, sir. Sir, I want to bring it before I retire. So hopefully I should. I don't know. I'm trying.
Thank you, madam. On behalf of
Thank you, sir.
IFP,
Thank you.
really thankful to ICH because LLRC madam and Dr. Kovagi, they have done very well. I think last month we have presented dengue CME, and since we are getting more of dengue cases.
Yes, sir. Too many dengue, sir.
I requested Dr. LLRC madam as well as Kovagi to present a case in dengue because it's definitely will give a good input to our postgraduates, particularly because they are the frontline workers. That's they are say they should well versed about the dengue management. Yeah, that's why I asked.
About lighting fan.
Yes. And really the
Sir, I would like to say it's a teamwork, sir. Just not one or two of us. The whole hospital, our PGs, everybody. I mean, it's a teamwork for the successful outcome of such sick children. Yeah.
Yeah, and Dr. Sajida Banu and other Triple S, they presented very well, and as well as they discussed very well also. And Dr. as usual, Dr. Thangavelu sir and Dr. Ramesh Kumar, they given that maximum input to our dengue cases as well as our postgraduates. They are very well benefited. I think that we have to ask our postgraduate how was it and how is your feedback.
Ask them, sir.
Yeah, Sajita.
Sajita, yeah.
Yes, sir. We had learned a lot of new points from each and every one of the professors present here, sir. And every point was a new learning point. We'll now know that there is some, we have to look for the sodium and chloride ratio, which is more important than isolated chloride. And then the significance of NRM, everything was a new learning point for us, sir. It was very useful, sir.
Yeah, Dr. Thangavelu sir, yeah, final.
As usual, sir, in a discussion, everybody learns.
Yeah.
Everybody learns. Nothing but a teacher or student. Everybody learn on their own merit. So I've also learned. I enjoyed the discussion throughout the presentation discussion. Thanks, Dr. Rajendran, Ismail, and then Gopal for giving us an opportunity to be part of this discussion. We always relish it. Thank you very much.
I think Sasikala want to tell. Yeah, Sasikala, see. Yeah.
Thank you, sir. Thank you. Approach to fever. So that approach to fever in a 1 week or less than 5 days child OPD triage by Dr. Thangavelu sir was also very helpful, sir. We will apply this in triage in our OP. And then we all three, we apologize for the interruption during presentation, sir.
Yeah, no problem. It's once in a while happening, no? We can't do anything. Yeah. Kovagi madam, yeah, please.
Sir, I was really happy, sir. By this class, even I had to revisit and look at dengue, and I have to read everything again. It was something new which I had learned. And Ramesh sir's discussion and Thangavelu sir's discussion, as usual, was full of so much of knowledge. When you hear it again and again, it's so happy to listen to my teacher as well. Thangavelu sir கேக்குறதுக்கு எனக்கு ரொம்ப I always feel happy and I feel happy to be a student always. Very nice listening to Dr. Ramesh's comments as well. Nice. My PGs have done a good job. I'm happy about it, sir.
Yeah, Dr. Ramesh. Yeah.
So the first thing is I'm so happy because in presence of Janwar sir, I learn many things. Always I will learn, and because sir will, I saw that small exercise how it make a lot of difference. Okay, I started so many things, and I know that polling madam also, because I don't know, because madam will not remember. And madam was then assistant professor Stanley. I am an intern. Okay, in 2002 and 2001 and 2, and really is a very happy moment. And I also, because yesterday only we lost one child because of severe dengue and leak, and we made a lot of depressing one, because the child was so, I know that the child will almost lost 5-6 years. Is in very good follow-up case of epilepsy clinic, and so within 5 hours, child was came within 5 hours, is went like anything. So that made a lot of research and reading. And because last year we did one platelet expression, the receptor markers that's why the platelet is on thrombocytopenia. I used to happy because they have some protection role rather than an higher thrombocytopenia. So those things, many things are learning and seeing. Then I always take classes because the innocent question by many times by the students will make me to read and learn more. Because last couple of week I'm engaged a lot of bedsides with undergraduates, and so it's really wonderful revision and learning. And I really thank this forum, particularly IAP, Tamil chapter, and Rajendran and the team invited me as moderator in this session.
Thank you, Dr. Ramesh. I'm really happy that past few weeks we are getting feedback, and there are a lot of even medical college professors and students are telling that they are going to IAP TNC YouTube channel. They're watching all the previous case presentation. They are claiming that they're really wonderful for them, and really for them for the exam going PGs, as well as even some of the senior professors also told that they are, before going to classes, they are watching that our presentation. Really they are useful for them. I'm really happy that IAP is something we are doing some better thing for our students community. And I think Thangavelu sir, I think all the senior faculties help us to bring this program very well. And as already previously told, that we are going to announce that best 3 awards for the case presentation to the Puduwai Pedikan. We shortly will, our judges, they will finally conclude and give the top 3 teams who have presented very well, and we will give the award in the Puduwai Pedikan. And next year also we are going to continue same thing, and we'll see that. Thank you, sir. Thank you.
Okay, sir. Thank you and good night, sir.